Now we move on to the last talk of the session, ocular toxicity with ATT. Are we missing the timely detection? By Dr. Aishwarya S., Assistant Professor, KMCT Medical College.
So very good morning to all. As for the physicians, for us ophthalmologists also, the ATT toxicity is always a topic of problem. So especially ethambutol, which remains a double-edged sword. So my question is, ocular toxicity with ATT, are we missing the timely detection? So just an introduction, the ATT regimen, the first 4 line drugs are isoniazid, rifampicin, pyrazinamide and ethambutol. Ethambutol is our culprit and it was invented in 1961. It acts by inhibiting arabinosyl transferase and thereby inhibiting the cell wall synthesis. So it is one of the safe and one of the systemically least toxic drugs. So the pulmonologist is relatively happy with this drug, but because of its chelating properties, we are not. So it's one of the drugs, within 2 years of invention, we could see optic neuropathy. And till from 1963 to 2024, there is no much treatment for the reverses of optic neuropathy. So the emphasis is always on early detection and stoppage. So why there is a sudden uproar about ethambutol toxicity? For that, you should know the evolution of TB elimination program in India. So RNTCP, according to the National Tuberculosis Program that was initiated in 1962, and in 1997, we had the DOT strategy. That is the directly observed treatment short course. According to that, the 4 line drugs were given in the presence of a supervisor. That was also fine. But in 2016, a daily weight band wise fixed drug regimen was based on the drug sensitive TB regimen was introduced. So that was the new guidelines. So what happened in the new guidelines? What is the comparison of the new and old guidelines showed that from the previous guideline, there was a thrice a week regimen. It was changed into a daily regimen, daily intake of the drug. And what was the change? Initially, there were 4 line drugs that was given singly. It was a single strip containing all the 4 drugs and that was taken together. But in the new, it is a single drug. That is a single tablet which contains all the 4 drugs together. That's a single tablet and that is taken. So according to that, there is a fixed dose combination as far as the weight band was introduced. And also, it was given in the continuation phase also. Ethambutol was continued in the continuation phase also. The total duration became from 2 months to 6 months. So this was that fixed drug regimen. According to that, you can see in the adult, it is a single tablet containing all 4 drugs. But in the pediatric, again, the 3 drugs are combined to a single tablet. But the ethambutol is given singly. So in this, you can understand the total duration increased from 2 months to 6 months. And also the total, and it was given according to the weight band. For example, for a 25 kg person, it's 2 tablets. And for a 70 kg and above, it is 5 tablets. So the total duration and also the total drug intake in this increased. So that is again a point of concern. So this was very happy for the pulmonologist because there was an increased patient acceptance due to fewer drugs to solo, increased health worker compliance because fewer tablets to handle, easy drug management, low risk of misuse of single drugs, and a low risk of drug resistance, which is a major problem in the case of TB. But what happened is, it took away the flexibility of modifying or eliminating the dosage of a single drug like ethambutol. So according to this, in the thrice a week regimen, the optic neuropathy was ranging from 0.3 to 12.6%, but in the daily regimen, according to the dose, it changed. For 15 mg per kg per day, it was 1 to 2.5%. But with 35 mg per kg per day, it increased up to 18%. So is ethambutol the only culprit in this? No. Something about isoniazid toxicity also. So isoniazid is less common. Around 11 cases of isoniazid-induced optic neuropathy has been reported in the literature so far. It is mainly due to the pyridoxal phosphate metabolism and it is dose dependent. That is about 2 to 108 grams causes optic neuropathies. The fixed drug regimen contains 75 mg of isoniazid. So it comes under this criteria. And it starts as early as from 10 days of commencement, but usually after 2 to 3 months of treatment. But what makes it different from ethambutol is this. That is the reversibility within 4 days of the stoppage of drug and usually a complete recovery within 4 weeks is expected. So it makes it a lesser problem. So now we'll go into the clinical presentation of ethambutol toxicity, the treatment options that are available, and the protocol for screening and follow-up, and finally, what is the need for reporting an ethambutol toxicity as an adverse drug reaction. So clinical presentation is usually within 3 to 5 months of use. It is usually a subacute, bilateral, painless symmetric loss of vision. It can be also an asymmetric and a sequential one. If it is a asymmetric one, pupils are usually normal in the initial stages. Then in an asymmetric case, it can be an RAPD, or in the symmetric, it can be bilateral sluggish pupillary reactions. And in the fundus, it can be initially normal, or it can present as a hyperemic disc, a few peripapillary hemorrhages or splinter hemorrhages, and finally in advanced case, that can be an optic disc pallor. So in the functional assessment, there'll be color vision loss, there is reduced contrast sensitivity, on field there is a central or centrocecal scotoma, RNFL there is initial thickening followed by thinning, and the thinning of the ganglion cell layer. On VP there is a delayed latency and reduced amplitude of the P100 wave. So is there any method to detect an ethambutol optic neuropathy before it has become a fully blown clinical picture? Yes, there is. We can see a ganglion cell loss, or if there is a prolonged VEP or a multifocal ERG, in RNFL initial thickening followed by thinning, or in visual field there is an initial reduction in the visual field index followed by a central or centrocecal scotomas. So when there is a color vision loss, contrast sensitivity loss, or a visual acuity loss, then there is a full-blown picture of ethambutol-induced optic neuropathy. So we had conducted a study in 2021-22. It was a prospective cohort study on ethambutol patients who are on ATT. We examined them on as a baseline, then for 1 month and at 6 months. So according to our study, the incidence was about 34.1%. A high incidence was seen at the end of 3 months of commencement of treatment, and a significant loss of superior temporal and mean RNFL thickness. So definitely ethambutol induced optic neuropathy was increasing. So now the question is whom, how, and when to screen and how to follow them. We would recommend a baseline ophthalmic examination at the start of the treatment for all patients, but definitely there are some high-risk candidates who should be closely followed up and screened before. So that includes malnourishment, renal disease, diabetes mellitus, tobacco or alcohol abuse, preverbal children, prolonged ethambutol therapy, and also when there is a combined therapy with linezolid, more than 15 mg per kg, or a total duration more than 28 days, and also in a low-weight patient. So the protocol for screening and follow-up is usually starting with visual acuity, color vision, contrast, and visual field. These are done in all centers, and in a higher center, you can go with an OCT RNFL and a VEP also. And a 2 monthly follow-up is required, and pediatric group and the high-risk candidate should be given a more close follow-up. One point is the consulting pulmonologist should also be encouraged to ask for drop-in vision and color desaturation. We would recommend to have a visual acuity chart in their OPD also for a basic screening. And the patient is also given awareness about this, and smartphone-based app should be given to them to educate to look for their own visual acuity, and on an Amsler grid to look for their central vision. So now coming to, what are the treatment options available? So there are no effective treatments to reverse the ethambutol toxicity. Stop the drug as early as possible is the dictum. So we can also give them a cocktail of vitamins including hydroxycobalamines, methylcobalamines, thiamine, and pyridoxine. And patient may also be started on ubiquitin, vitamin C, zinc, and copper because they have chelating properties on the micro elements. And if there is no improvement within 4 to 6 weeks, again discuss with the pulmonologist and considers the stoppage of isoniazid, which may be potentiating the toxicity. What is the importance of reporting ethambutol toxicity? It is the responsibility of both pulmonologist and ophthalmologist to report ethambutol toxicity. There is a pharmacovigilance program of India launched by the Ministry of Health and Family Welfare in 2010, and the hospitals and TB centers. Only if you take this report the adverse drug reactions and take it into a national level, then you can make a remedial measure at the policy making level. So to summarize the clinical presentations, there is a decrease in vision or a quality of vision. Ocular examination include visual acuity, pupil for RAPD or sluggish reaction, fundus for a hyperemic disc or an optic disc pallor, color vision contrast will be impaired, supportive in visual field there may be centrocecal scotoma, optic disc there RNFL thickening followed by thinning and a prolonged VEP. The more importance is on creating an awareness to the physician and patients. A 2 monthly visit should be given, and there will be self-assessment of to be educated for the patient also. Treatment: the stoppage of the drug is the dictum. If no improvement, consider stoppage of isoniazid acid and linezolid. So, in the absence of a definitive treatment, it is emphasis always on primary prevention. So, report ethambutol toxicity as an adverse drug reaction when you see one, to bring a change at the policy making level. Thank you.
Thank you, Aishwarya, for that wonderful talk. Actually, it is so important, ocular toxicity of ATT, so that we are actually in a position, where we don't know how the patient will respond to this ATT, whether they'll develop this ethambutol toxicity. And most importantly, as she said, we have to educate the patient that this can occur, and home-based vision assessment can be done so that it can be detected early.